Hello everyone. Earlier we studied the definition of CRF, the stages of CKD, and the etiology. Next, we will study the clinical manifestation and the diagnosis of CRF. The kidney is highly compensatory. As long as more than 15% of renal function is preserved, the homeostasis is maintained. Even in the early stages of CRF, patients often have no obvious clinical symptoms. The manifestation of uremia do not appear until most of renal function is lost, or patients with CKD suffer from repeat deterioration due to stress. Especially chronic dialysis can reduce the incidence and the severity of many of these disturbances, so that the overt and florid manifestations of uremia have largely disappeared in the modern health setting. So the first character of CRF is asymptomatic. The second character of CRF is symptom non-specific. Although uremia can lead to disturbance in the function of virtually every organ system, the manifestations of each system are not specific and can occur in other systemic diseases too. First, gastrointestinal abnormalities. We can smell a urine-like odor on uremia patients' breath. Anorexia and morning nausea and vomiting are common early manifestations of uremia. The gastrointestinal tract of advanced patients may have mucosal erosion, ulcers, and gastrointestinal bleeding. Second, cardiovascular system disease. Cardiovascular system disease is the leading cause of morbidity and mortality in patients at every stage of CRF. There are mainly four aspects, namely hypertension and left ventricular hypertrophy, congestive heart failure, atherosclerosis, and peripheral vasculopathy, pericarditis. Among them, it should be noted that hypertension is the most common cardiovascular complication and is also the basis for left ventricular hypertrophy and heart failure. About 95% of patients with CKD progressing to end-stage renal failure are complicated with hypertension, which is mainly caused by excessive volume load caused by salt and water retention and increased extracellular fluid, elevated renin level, and sympathetic excitation, and so on. Abnormal cardiac function secondary to myocardial ischemia, left ventricular hypertrophy, in combination with the salt and water retention, often results in heart failure or even episodes of pulmonary edema. Heart failure is the most common and dangerous cause of cardiovascular complications and deaths in CKD. Heart failure can be a consequence of diastolic or systolic dysfunction or both. About 15 to 20% of patients can develop pleuritis, and with pulmonary metastatic calcification associated with calcium and phosphorus metabolism disorders. 5. Neuromuscular system injury include three aspects. First, central nervous system. Disturbance in memory, sleep, and concentration even lead to seizure and coma. We called it uremia encephalopathy. Second, peripheral neuropathy. The typical manifestation is restless-like, similar to diabetic peripheral neuropathy, severe at night, and affect sleep. Third, neuromuscular dysfunction, including creep, twitching, hiccup. 6. The metallurgical system, pruritus, stubborn, continued, and intractable. The cause of pruritus is partly due to hyperphosphatemia, partly due to the deposition of uremic frost on the skin. 7. Bone disease. The bone disease caused by CKD is called renal osteodystrophy. Although only 10% of patients with chronic renal failure have symptoms of bone disease before dialysis, relying on radiation and a bone biopsy can increase the diagnostic detection rate. Renal osteodystrophy contains two disorders, namely high turnover bone disease and low turnover bone disease. High turnover bone disease is more common, while low turnover bone disease is more dangerous, which leads to metastatic extraosseous calcification. For example, pulmonary heart valves, vascular edema, and whatever are involved. Once bone disease occurs, it cannot be resolved, so the emphasis is on prevention. Disorder of calcium and phosphorus metabolism lead to secondary hyperparathyroidism, endocrinal system abnormalities, and infection. Everyone just know them. It's okay, and we are not going to go through all of this in details. Of course, we can also look sideways for signs of renal failure, such as urine volume. Second, we should determine whether it's acute or chronic. Medical history and complications are important clues. Glomerular disease, oncoturia, chronic metabolic bone disease with hyperphosphatemia, hypocalcemia, elevated PTH, normocytic and normochromic anemia, small kidney, and so on. Don't rush to exclude CRF when the size of kidney is not small. Please be screened for the following diseases, including lymphoma, amyloidosis, polycystic, and diabetes. Next, we should state it based on estimated GFR levels when the diagnosis of CRF is established. Next step, we need to look for risk factors and actively remove them. Common risk factors include old age, infection, hypertension, bleeding, heart failure, or drugs. Complications cannot be ignored simultaneously. Finally, we try to find the primary disease, but most of patients have lost the opportunity to find the primary disease and can only make reasonable inference. Okay, that's all for today's class. I hope you can further consolidate what you have learned today after class. Next time, we will learn about the treatment of CRF. Thank you.